Hello, I'm Norman Swan. Welcome to Getting Started with the PCEHR. I'll get that right by the end of the programme. The Personally Controlled Electronic Health Record, and we're coming to you on the Rural Health Channel. I'd like to acknowledge that this programme is being broadcast from the land of the Wangal people of the Darug tribe, traditional custodians of the land, and we pay respects to elders past and present. The Australian Government's Personally Controlled Electronic Health Record, the PCEHR, is part of the federal government's health reform agenda. Tonight we'll talk about myths and misconceptions about the PCEHR and what you can reasonably expect from it at this stage. We'll also help you understand the various options for registration, including the new simplified and fast assisted registration tool. By the way, this Rural Health Education Foundation programme not only helps you with all that, it also gives you accreditation and CPD opportunities. We're coming to you live via webcast and on the Rural Health Channel. So to get in touch and ask your questions, comments, whatever you want to say, via phone, text, email, fax or online. Send your emails to questions@rhef.com.au. You can text us on 0408 408 932. You can phone us. I know it's old-fashioned, but you can phone us, 1800 817 268. And you remember fax machines? Well, if you've still got one, you can fax us on 1800 633 410. We'll be very impressed if you've still got a fax machine. And if you're watching via the webcast on your computer, you can type the questions into live talk box and click submit. We're taking questions live throughout the panel discussion, so please send them in as they arise or occur to you. Our first question to you, though, is it would be good to know who's watching tonight. So let us know what profession you belong to, whether you're a GP, a nurse, an Aboriginal or Torres Strait Islander health worker or practitioner, pharmacist, allied health practitioner, a specialist, you can be a specialist whatever you like, a student, a manager or other. Let me introduce the panel to you, though. While you're answering that question, you just click on the answer and we'll come back with the results shortly. Mukesh Haikerwal is a general practitioner in Melbourne's western suburbs, where he's practiced for quite a while. He was the national president of the AMA from 2005 to 2007. He's currently working with NITA, the National eHealth Transition Authority, as well as being chair of the Council of the World Medical Association. Welcome, Mukesh.
Thank you.
Did I miss anything?
Lots, but don't worry.
All right. Lots that probably would rather people not know. Chris Mitchell is Head of Adoption, Benefits and Change at NITA, the National eHealth Transition Authority. He's worked as a rural GP for more than 20 years in northern New South Wales. Welcome, Chris.
Thank you.
Chris is a former president of the Australian College of General Practitioners and a clinical professor at the University of Wollongong. Eleanor Pritchard is the team leader for eHealth at the ACT Medicare Local. Welcome, Eleanor.
Thanks, Norman.
Eleanor is responsible for the local implementation of national eHealth initiatives, including the PCEHR. And last and certainly not least is Adrian Barrett, who is a health service manager at St Vincent's Hospital in Sydney. His role includes implementing the national eHealth record system within St Vincent's public and private hospitals. And good luck to him with private specialists at St Vincent Clinic. Welcome, Adrian.
Thank you, Norman.
Welcome to you all. What are you up to there at the hospital? You're one of the pilot sites, aren't you?
We are one of the 12 eHealth pilot sites, and we have been implementing the PCEHR in our public and private hospitals, and we've been live now for several months with the PCEHR in the public and private hospitals.
And you've got a lot of rural and remote patients and practices registering with you.
Yeah, that's right. Well over half of our registrations that are coming from rural and remote areas of particularly New South Wales, but in fact we've had registrations from all over the country, and that's primarily relating to our cardiothoracic transplant program within the hospital, that our patients are coming from far and wide.
Right. How are the registrations going, Chris?
So consumer registrations are over 90,000 now. We're getting about 1,000 registrations.
Last time I looked it was 15.
Well, it is increasing. We're getting about 1,000 a day, almost 1,000 a day, and a lot of that is being driven by the assisted registration tool, which we'll be talking about today, which allows providers to register within their practice if they wish to.
And what's the proportion of people who are registering from rural and remote sites and homes?
So rural Australia makes up about 30% of Australia's population. In terms of registrations, the registration is a little under that, so we're running at around 20% rural registration. But that's still surprisingly high. A lot of the investment has been in eHealth sites, and a lot of those eHealth sites are metro. I think it's really important for all of us to do what we can to close the gap between mortality in rural Australia, particularly remote Australia and our urban practices. And I think a better connected health system helps do that. And I think the eHealth record is part of that solution.
So tell me where we're at as of today, because it's a moving feast. It's changing all the time. We really are in a developmental phase, Mukesh. Where are we at now with the PCEHR?
To make the PCEHR, the eHealth system in Australia, work, we need a good critical mass of practitioners to be part of that process, and we need consumers, you and I, the members of the public, to be participating in this whole program.
So have you registered as a patient?
I'm registered as a patient. All my family is registered as a patient, and in fact in my practice we, over the summer months, registered about 250 patients to give a real field trial to the way in which the whole record works. So I'm registered, and the practice, I personally registered with my numbers I need to register and started sending up shared health summaries and so on from December.
That you needed to? What's the needed to bit?
To register for the PCEHR, I need to have my various numbers, my personal identifier.
Oh, I see. They coded the codes rather than there's not some person telling you you've got to get to 250, otherwise you don't get paid next week.
No,
right?
no. This is me trying to. If I'm going to ask others to do this, I need to have taken the journey myself.
Yeah. So what's on the record?
So the record came into being on the 1st of July, and the first cut brought into play consumer registration, where consumers could register online, and that process has improved from being 29 screens down to about 8, and Chris will talk about the assisted registration tool a little bit later on, which helps that process as well.
So you no longer have to go into a Medicare office to do it?
Well, you wouldn't have had much success if you went to a Medicare office anyway, because they're having great difficulty registering from there. The real options were doing this online or doing it using the phone, because there was a lack of capacity in the Medicare offices. But nonetheless, people have registered. We as practitioners have started to register as well. And when people get a registered a record, they will see immediately, when the record becomes active, a dump of the last 2 years' worth of Medicare benefits that they have accrued. The Medicare benefit schedule items include the name of drugs that they have, whether they are on the Australian Organ Donation Register, and also if they're a child, what immunisations that they have from the Childhood Immunisation Register. So that's something that initially seems like not being very much, but working in practice and working with these patients and new patients, there is some benefit coming through from having those. And what we're seeing now is additional benefits as people's clinical information systems, Medical Director, ZMed, Best Practice, MedTech 2032 and the like, start getting connected. It means we can start sending clinical documents of value, summary clinical documents that can add to the patient journey by allowing good, reputable clinical information to be available from one practitioner to another.
So is all this shared? Is everything shared, Chris? That means that other people can...
So the share is... So the National eHealth Record System is fundamentally a system to allow consumers to share the information that they want with their provider of choice. So whoever they want to share it with, they can share it with. When you register, the default is that you share with everyone, but if you want to restrict access of different healthcare organisations to information, you can do that. Less than 1% of people who have registered have chosen to restrict access, so basically most people are sharing. And I just want to emphasise something that Mukesh said. The PBS, the Pharmaceutical Benefit Scheme, the subsidised medicines, patients have the opportunity of loading that up when they join, and that is really valuable information, and the way it's presented is really valuable as well. You know, for those of us working in rural EDs, you know, we're sick of trying to work out what tablet it is based on somebody's recollection of the colour. And that PBS covers 75% of the dispensed medicine. So that's really important information that's available right now. It'll get richer with more information, but that's a big win right now.
And how tough is it to put the shared summary on there?
Well, the shared summary uses the practice management software that we have already. So part of the...
So this is the problem-oriented medical record. When you've got your summary in front, diagnoses, history, allergies, that's really what you're going to put in front.
That's exactly right. So this is what we've been doing for...
So if you're an accredited practice, that's what you're doing.
Using IRCGP standards, started with a paper record, and the paper way of doing it, and we've transferred the settings for that into the electronic world. So the shared health summary basically is derived from what's in our clinical information system packages, and there's a template that as you connect to the PCEHR, you can, Personally Controlled Electronic Health Record, you can select which of those diagnoses, medications, allergies are correct, make sure the patient's comfortable with that, and then upload it. But that takes 25, 30 years of clinical practice and having a system and making sure that the knowledge is there in a way that can be used.
What myths and misconceptions are you finding out there about PCEHR when you talk to other general practitioners, Eleanor? I
mean, there's a few myths and misconceptions out there, and one of them is that a GP is always going to have to look at a person's person-controlled eHealth record. So, you know, I've had GPs say to me, every time a patient comes in, do I have to look at their eHealth record? And I've said, well, if it's your regular patient, then no, you have all that information. So what's more important is that you work with your patient to create that shared health summary, that summary of their important information to upload for other healthcare providers to look at. But for your regular patient, that you have all their health information, you're their regular GP, you know, you're ordering their tests and, you know, seeing what allied health that you're referring them to, you have that information too.
And so if you were going to change the summary in the front of your electronic record, which is already on your computer system, you've got to do it on. Does it double handling? Have you got to double enter?
Well, because you've already entered in the information into your clinical software that you normally do, it's just a matter of, you know, checking it, confirming it with the patient, getting that consent, and then, you know, uploading a new shared health summary if something changes in that patient's conditions.
Does that take a long time, Adrian?
Look, it's very quick. In the experience that I've had working with some of the clinical desktop systems to create a shared health summary, it is in minutes. I think the really critical question here is how good's
the information to start
with. That's exactly,
right.
Exactly right. Yeah.
And you were saying before we came on air, there's some scrubbing that needs to be done. And
well, there is, but there are always going to be times when the record is likely to be in a really good shape, and that would be a good time to target sharing that information when you've done a health assessment or a home medication review, or for people with chronic and complex health conditions when you're doing a GP management plan or team care arrangements, or when you're referring to a specialist or sending somebody to the hospital. These are times when most of us do look at the summary that's on our record and make sure it's up to date. The other thing that we did in our practice, which was one of the eCollaboratives practices that was rolling out some of these, was to actually print out the patient's health summary and give it to them when they're in the waiting room before they came in to see me, so that they could have the opportunity of updating it. It's not very high tech, just updating it on paper, but it saved me a lot of time. And look, the reality is even good practices, the data quality isn't always 100%. So there is some new workflow there for particularly general practice. The shared health summary can actually be sent up from anybody involved in the long-term.
But that's a practice improvement thing.
Look, it makes a big difference to the quality of your records, and I think it means that you're able to provide better care. So it has value for the practice as well.
Mukesh?
Yeah, look, the difficult part of this is getting the record right, and that's as we've stated just now, a very much a pride thing in the quality of the record that we provide and the letters we generate from that. But also it's about getting the technology right as well. And what we're finding is, yes, the actual upload may not be too difficult, but getting ready for all that, we've really got to understand that that's not an easy process. And I think that's been recognised by the Minister in the comments she's made about this, and the Medicare access is available for this purpose further down when people start uploading.
But it's a lot easier now than it was.
It's much easier now than it was.
Let's get the answer to that first poll question which I asked, which is who's watching, who's out there tonight? And there's 16% of your GPs, 25% nurses. Unfortunately, we don't have any Aboriginal and Torres Strait Islander health workers or practitioners. That's watching on the webcast. I'm sure there are millions watching via the regular cast. 10% pharmacists, 9%, and quite a few allied health, and a small number of specialist students, and the odd manager, that's good. And 32% are other. I don't know what other is, but let's hope that you're consumers and that you're actually going to push your practitioner into registering and get you registered. My next question to you is, those of you watching via webcast, is how much do you already know about the PCEHR? Quite a lot, a bit, but not enough, not much at all. What does a patient need to register with PCEHR?
Well, I mean, there's lots of ways to register. I registered online, so to register online, I just needed, my identification details. I also needed to know when my last GP visit was. So for me, I did it the day after I last went to a GP. So that was very easy to do that online. But we can also use this new assisted registration tool.
I just want to go through some of the questions that we've got from our webcast audience. Thelma Tantalos asks, who's a pharmacist from Tasmania, it looks like. Did you say 2 years of drug history will show too? Is that 2 years of drug history?
It's 2 years of the PBS, so the Pharmaceutical Benefits Scheme past information. And that information's already held by DHS, and some people can already see that online, if they're making the effort to access it. But Mikesh...
Yeah, and so there is a slight additional to that. So if you've got a list of medications for the last 2 years, and some medications are connected to that, you'll get a history predating that 2 years as well. But in general, it's a 2-year dump of information from the MBS, PBS, Pharmaceutical Benefits Scheme, Medical Benefits Scheme database, which you can see on your PCEHR.
A question from Tracy Maynard, I think also from Tasmania, from a Medicare local, asks what work has been done with residential aged care facilities. Christopher?
Well, there's a lot of work that's gone on to support the vendors that actually produce the software that rolls out to the aged care system. That's not as well advanced as the general practice software, but that will be rolling out through the year. That will allow aged care facilities that use a clinical information system to share to the personally controlled electronic health record if they choose. Look, the
GP who visits obviously can have access in his or her own practice.
Yeah, absolutely. But I think the feedback that we certainly get from the aged care sector, it's this transition of care from the aged care sector to the hospital and from the hospital to the aged care sector. It's the information with those transitions that's really critically important, and in order to get that we need hospitals and aged care vendors on board.
John Malloy asks, I think from New South Wales, asks, I'm an optometrist, will relevant information be available to allied health practitioners, and will we be able to add information?
So the answer is that all healthcare providers will be part of the build. If you are a registered health professional through the APRA scheme, Australian Health Practitioner Agency, you're already on, you already have a health identifier, and you have the ability to get a health identifier for your organisation.
So even if you're not necessarily able to bill through Medicare, as long as you're registered through the authority, you can
Yes, you get those. And those who are not registered with APRA, the registrable practitioners like speech therapists, exercise physiologists, there is a scheme for getting your health identifiers as well through Medicare. And so the answer is yes, we want people to participate in this scheme from every discipline.
What about the community? Another question comes from Stephanie asking about the Aboriginal community-controlled health centres. Presumably they're just like general practices and registered accordingly.
Well, they're not just like general practices, but...
well, I mean in that sense.
Well, in that sense, often the clinical information systems they use are similar, and they've been covered off by and large by the GP vendor panels. We are running out a program in 13 AMSs to make sure that the policies and processes that we've got for general practice are also going to be fit for purpose in that environment, and the learnings from that will be rolling out with the support of NACCHO and also AMSANT particularly to get that information out to community-controlled health sectors.
Now, don't forget, if you're watching via the regular way, via the old-fashioned telly, you can ask a question, you can fax it into us, you can phone us. The phone number is 1-800-817-258, I think that's right, and we'll show you the numbers on the screen in a moment, and you can phone and fax us with your questions too. Adrian, do you need broadband in your practice if you're out in a remote location?
You certainly do need a reliable internet connection. I mean, you could realistically access the PCEHR via dial-up, but that would be only in instances where you are dialing in. But you really need a fairly reliable broadband connection.
A question from Jenny Donaldson asks, can you give us a sense of what's the buy-in for allied health at this early stage? Is it only secured messaging, or?
Well, allied health they absolutely need to be part of the system. We in general practice are prepared through various schemes that have been out there, and we're at a level that we've got 98% of general practitioners ready to participate in using technology in the health sector, and many of those will be using this system. We need to communicate with all practitioners in the media, in the community. So, you know, the buy-in is being able to get good information, good summary information about the patient who's before you. You should get that from the referral from the GP, but often those referral letters don't come to you, and they will help get that information to you from a reputable source. And also, you've got other information available from other places, and you can see medications, and even when you last did the consultations, whether your 5 consultations for the year are due to be renewed or not. So there's some benefits now and many more later when these documents come in. And if you've got a clinical information system, you can upload the summary information in the form of an event summary of what you've done for the patient. So there is some continuity, one practitioner to the other, of the care of that one patient.
Yes, could I just make another comment? And because I think this is really important benefit for allied health. You know, I by and large, I'll usually get the discharge summary from the hospital anyway. It'll usually be sent to me because I'm looking after the person on a regular basis. But it's very unusual for the speech therapist or the physio down the road to also get a copy of that discharge summary, and that is critical information for them in managing their patients when they've been discharged from hospital. So this is really about connecting our health system.
So it's one less phone call you've got to make.
Allied Health will really benefit from it, and while they will need a clinical information system to share information, they can actually receive information that's there just through their browser if they register.
Yeah. And they're already very keen to be involved. I mean, Allied Health are really keen to be involved in eHealth and PCEHR, and so they'll be accessing the provider portal and, you know, actually seeing this information.
We've certainly been doing work with ARPA, the Allied Health Professionals, and also SARA, which is the regional Allied Health providers. And, you know, we now have a Chief Allied Health Officer coming through. So I think the standing of Allied Health in the community is being recognised, which is really good.
So are all practice software systems now compatible with PCEHR?
No. So there are 8 tools that you can use at the moment for GP systems that will connect with the PCEHR.
So you kind of got to download a dongle or something? Or
no. So if you've got that system, it's been funded to build to be able to be connected to the system. I can go through them, and I probably won't. But we've also got 3 aged care sector providers and some pharmacy providers as well. And we're now trying to get to work with the...
So if you look at the market for clinical software systems, how covered are you with what?
Well, we've got 96%, Chris?
Yeah, so we're well over 90% for general practice. The other areas haven't been released. You know, they're not available yet, but our aim is to cover 90% of pharmacy and aged care as well. But look, I mean, we do hear that work needs to be done for allied health. We do hear that. We need to start somewhere, and we've started in those 3 areas.
So, Eleanor, what does a practice need to get going?
So they need to get some identifying numbers that Mukesh alluded to earlier. So the first one for the organisation is the Healthcare Provider Identifier Organisation, or HPIO, or HIPPO as some people call it. And then there's provider identifiers, which are HIPPIs, or Healthcare Provider Identifier Individuals, HPIIs.
And how hard is it to get those?
It's not hard. I mean, you know, it's a bit of a cumbersome form. It's not at all hard. And Medicare Locals are there to help you as well. You know, as a healthcare provider organisation, you know, your Medicare Local can help. Once you get your HPIO for your organisation, you need to get a NASH certificate, National Authentication Service for Health certificate. It comes on a CD, and it's basically a digital credential that allows your system to access the PCEHR securely.
So that's a once-only load. You stick that in.
Once only, stick that in. And then once you've done that, you've registered with the PCEHR system, you're in. And you've got your conformance software. You'll actually be able to start accessing, viewing patients' eHealth records, uploading shared health summaries.
And briefly, what does the patient need?
Well, the patient just needs to register.
Right.
So to do that, basically, you know, identification and verifying your identity is the cornerstone of registering.
So we actually have a pseudo-patient in the studio with us. Mukesh, could you go and have a chat to Janet, who might or might not be interested in registering for a PCEHR?
Good evening.
Hi, how are you?
Janet?
Good. I'm going travelling with my husband, Tom. We're going to go off. We've got a van. And I have heard about this electronic health records thing
Yes.
system, and I thought it might be something that would be useful for me because I've got a bit of a history.
Well, it's good to see you, and you're looking great. And going travelling, that sounds like a great idea. How far away are you going?
Oh, well, I won't bore you with the details, but as far as we can, in as much time as we can afford.
I think you're an ideal candidate for a personally controlled electronic health record.
Right.
And that is, we've known each other for quite some time.
Yeah, absolutely.
I have a significant amount of your health information on my computer system here already. That allows me to be able to provide you directly through a printout of that information.
Well, we used to only be able to get a printout.
But if you register for the PCEHR, we can help you with that, you will be able to have a summary that I provide onto that personal control electronic health
other
record.
doctors will be able to
so that
have
you can see
access.
it and other doctors can see
that's
it.
really what I'm worried about, because I have ongoing medications and things. But the other thing is Mum, because you know she's in the nursing home, and I'm basically been taking care of what's happening for her and keeping a track on what's going on. And I'm wondering whether that be something that I could, whether it would be helpful in that way
it's
as well.
fantastic that you do keep an eye on Mum, and that's really been helpful for us to help look after her as well.
Yeah.
Obviously, she needs to make her own decision about having that record.
Right,
but if she did have that, it would be very useful for her. But she can also make you a nominated representative on that, and with that, you can have a look through from a distance while you're travelling at some of those information about her, and keep people in the loop as well.
Yeah,
so
well,
I
that's
think
really what I need, and you think that'll work for us. So if that's going to be useful, I think I'd like to register both of us.
Yeah, well, we need to register yourself first, and there are many ways of doing that.
Okay.
One is you can actually do that yourself by going online. We also
so I have
some,
to go and do that.
You can do it online. We actually have something here called the assisted registration tool, which will show you with one of my staff.
So I could do it here.
One of my staff,
because I'm not real good on.
Sure.
You know,
look, it's not as scary as it sounds, but it's actually. But we can certainly help you with that process.
Okay.
And the benefits for you are that you'll get a set of summary information about you that we have already, that we'll agree on, and we can upload that, and that can be ready for you to look at, to look after your health better, and for anybody else that you visit to be able to see that
What's more important for someone else to look at it? I know about me, but I want other people to be able to know about me. I want Tom to be registered too, my husband.
That certainly can be done as well using this, this tool.
Thank you very much, Mukesh. Thank you, Janet. We'll come back to you in a moment. And while we're doing that, let's get the results of the poll question 2. How much do you already know about the PCEHR? Well, a third of you said quite a lot, a third of you thought a bit, and a third of you thought not much at all. So we hope to help at least 60 odd % of you do that. So thanks very much for that. So what we're talking about now is the assisted registration tool, and helping you with that, and the steps that you need to take to do that. Eleanor, do you want to take Janet through the next part of the process?
I'd love to.
Hi.
Hello, Janet. How you going? I'm Eleanor.
Yeah.
So I'm the practice manager here at Mukesh's practice.
Oh, okay.
So he told me you're interested in registering for your own eHealth record today.
Yes, that's right.
So I'm just going to talk you through how we can help you do that today, right here.
Okay. Do you need my licence or anything?
Well, we just need you to, we need informed consent to actually process your registration. So we just need you to read some information, and then we get you to complete a form and just sign the form.
Okay.
Then what I do is...
So this basically says, I want you to do this.
Exactly, yeah. So that's your signature, you know, to consent to your eHealth record being created. So then I will scan the form into our computer, and we basically use a tool.
So you'll do it for me?
Yep. And
I just have to fill this in?
Just a one-page form, yep. We use the tool to create the eHealth record, and then as soon as that's done, you'll be able to have an appointment with your GP to discuss what information you want on there.
So also, not all my information goes up. I thought it would all just go up.
No, not automatically. There is some information that will go up automatically. So your past Medicare benefits service information. So, you know, when you come here and you have an MBS item, you get that information. And also pharmaceutical benefit scheme information. So you'll be able to see some of the past prescription information you may have had.
Oh, but not everything else?
Not everything, because you need to have that conversation with your GP. Well, exactly. So you have that conversation with your GP about what is the most important information to be uploaded for you know, to be shared on your eHealth record.
Okay, and how do I actually look at it myself?
So we'll actually give you a brochure, because you'll get an email where you get sent a code so you can actually access it online.
So after you register me,
after we register you, you get sent an email. There's a link in there, and it's just, you know, some simple steps to follow so you can set up online access.
Okay, I just follow it.
You just follow it, and you can access it just via the internet, basically wherever you are.
Oh, okay. But you said I'd get an email.
Yes.
With my code, is that right? Yeah,
Yes, that's correct.
I'm thinking I'm wanting to register Mum as well,
Yep.
and she doesn't have an email or anything, like she doesn't have any new electronic anything. So what happens with that?
Well, to register your mum, it's important that you have a conversation with her, or that you bring her in, and so we can have a conversation with her about the record.
So I should make an appointment to bring her in?
And see that she wants to register, and then she'll have to go through the same process of consenting to have an eHealth record.
Yeah.
But then we can actually process that registration while she's actually in with the doctor, and then when she comes out, we can actually give her that code. And
oh, wow, is that quick?
It's that quick, yeah.
Wow.
She might want to then give that code to you so that you can access her record.
Yeah.
Because
so
if
I
you're
wouldn't be
still
able
looking
to
after
access her records unless I had the code?
Unless you had, her permission.
Okay, yeah, well, I don't think she'll have a problem with that. Yeah,
of course
no.
not.
Well, I usually bring her in anyway, so yeah, I'll
Fantastic.
just make an appointment for her.
Well, that'd be great.
Yeah, okay, that sounds good.
Thank you very much indeed. Thank you, Eleanor. Thank you, Janet. So Mukesh is otherwise engaged now, and Chris Mitchell, of course, is his partner who sees Janet a lot. Janet has lots of issues in her past history, and now's the time for Chris to have a chat to Janet about what's going to go on to the health summary and what might not go on. Chris?
Hi, Janet.
Hi.
Chris.
Yeah,
How
hi.
can I help?
Well, I'm just I've just registered for this electronic thing, and I'm actually wanting to. Well, they said I had to talk to you about what I should put up there, or what you should put up there.
So you've registered for the eHealth record.
Yeah, and they said everything doesn't go up automatically.
So one of the documents that is really valuable for other people involved in your care is it's called the Shared Health Summary, but it's a summary that's a created summary of your history over the time that we've known each other.
Long time.
Well, it seems like a long time.
Yeah.
and so that important summary information that I would normally include in referrals to specialists or in letters that I might send to the hospital. That's my GP health summary, and the information.
So that's basically just a summing up of what's on my whole records.
It's a history of your major medical history, your allergies and adverse reactions to medications in the past, your current medication list, and your vaccination status. When you had a flu needle last. Pneumovax, things like that.
So when I'm travelling, if I go to see a doctor, if I have to go and see someone, are all doctors linked into this system?
That information is really valuable for anyone that you see, not just doctors. It's really valuable for the hospital.
So if
it's
I want
really
to see a physio
valuable
or
for
someone.
physiotherapists, but it is valuable for other GPs. Now, just as you've had to read some of the terms and conditions around that record, providers have to do the same thing. So in answer to your question, not every practice in Australia is registered yet.
Okay, so if I'm going to a doctor, should I just check with them whether they're registered? Is that the idea?
Well, this is very early days for the record, and at the moment there are far more providers that are not registered than providers that are registered. If this is critical to your care right now, that's something that you may choose to check. But the other thing is you'll actually have access to this information yourself. And that's available to you on an iPad or a PC or anything. So that information can be shared with the provider even if they're not registered, if you wish to share it with them.
To them.
But ideally, if you want providers to be able to contribute to that record in your travels, they will need to be registered. But in answer to your question,
what do you mean by if they're going to contribute?
If you see one of my professional colleagues on your travels and you want information from that consultation to be shared into your eHealth record,
from that consultation,
they will need to be registered.
They can put it in.
That's correct.
Okay. Yeah. All right.
But
so what's this summary look like?
Well, this is what your GP summary looks like now. This is the summary that we use in the practice with the different doctors and the nurses in our practice as a summary of your health status.
Yeah, I noticed that you've got my depression up here. I'm not having any trouble with that anymore. I'm not taking any medication or anything. I'm just thinking maybe that's something that would be better not there, because some people think that depression is causing things that's got nothing to do with it. I don't know whether I'm explaining myself very well, but I'm just wondering if that would affect how people, look at my state if I...
Well, look,
Does that make sense?
I'm hearing your concern. I've got a couple of things I'd like to say. First off, I think the more complete your record is, the more valuable it is for other people involved in your care. Now, if you believe that information, you really would rather not have it in the record, look, I don't think it needs to be in the record. It's not a current active problem for you. You're not having any treatment for it. If you don't want it in the record, it doesn't have to be in the record. But I would say that there are some things in the record that are critically important that we would want to have a discussion with if you wanted to suppress it. So if there was, if there was a really important medication that you're on, for example, that had potential for interactions, or if there was an active problem that would affect the way we deliver care to you. And depression can be like that sometimes.
Depression isn't really...
Look, I think in this particular case, I'm comfortable with that. We've had a discussion and we've got a shared understanding. But I think the important part is having that shared understanding. The value of the shared health summary is greater the more information that's in it, because that'll affect the quality of care that other people can provide.
So you think maybe it's good to leave it in?
I don't think people will be discriminating you on the basis of that. I think let's just have a discussion. Whatever you decide, I'll be comfortable to support.
All right. Well, look, I'll have a think about it and I'll let you know. I mean, if I don't get back to you, you can leave it there. Is that okay?
Well, we'll be sending the shared health summary up at the end of this consultation if you'd like. If you're happy to have it in, I'm happy for it to go up. If you don't want it in, we don't have to put it up.
Okay.
If you change your mind in the future, we could certainly come and have a chat about what you'd like in the shared health summary.
So things can be changed?
We update the shared health summary when there's a significant change in your status. But if there's something that you feel, in retrospect, you'd like to have a discussion with, rather than just emailing me or texting me or calling me, why don't we come in and have a proper conversation about it?
All right,
We'll be really clear what gets shared. So when you're ready to tell me what you'd like in there or not, that's what we'll share at the end of the consultation.
All right, I'll get back to you. Okay.
Thank you very much indeed. So, Adrian, do people get rejected? Do their applications ever get rejected?
Never get rejected. It may not be successful because the details that we've provided in the registration process may not match what DHS Medicare have on file for that patient. But that instance, in my experience, has been rare.
So this is usually an identification issue?
That's right.
Just to be absolutely sure.
It's not that rare. In our practice we would have 80% matches. So we've been trying to bring down the health identifiers into our clinical software package and trying to match that up with Medicare. Some of that's to do with having old data on our home systems in the practice. Some it's because the numbers that Medicare have, the date of birth, may be wrong and they need to be re-registered. And there are problems like that. I wouldn't want people to think it's...
So in a sense, it is like data scrubbing. I mean, once you start getting this data out there, this is just purifying the system in a sense.
It is, but it's not a completely new workflow for many of us who are already using online billing. We've got to go through those processes to create that link with DHS Medicare for online billing. It's not that dissimilar a process.
Do you have to keep this consent form?
What we do is we scan the form and we attach it when we actually process the registration, and then we've chosen as the ACT Medicare Local to shred the forms. If we were in a practice helping someone register, once we process their application, if we've scanned and attached the consent, we can actually give the consent form back to the consumer. Alternatively, we can actually post those forms into DOHA, because the consent forms need to be kept because they are consenting to be part of a system. And if you're registering online, then you've completed consent online. And it's the same thing with the assisted registration, that consent form does need to be kept in a certain manner, whether it's electronic or whether it's posted in a hard copy form.
Norman, I'd just like to emphasise something, because the assisted registration tool is a really wonderful tool, and it's really mostly going to be used in practices for patients who the practice really wants to see registered. I mean, you've seen that there is some time involved in that process, and there is no expectation that the practice is going to be donating their practice management or receptionists or practice nurses or doctors' time to these processes for everyone. But for people that they really want to see registered, it makes an easy way to register. The vast majority of registrations are online.
So give me an example of the sort of people that you're registering.
So in my practice, the sort of people, well, the people that I want to register in my practice are people that I think are going to have particular difficulty registering online. So if, you know, for my patients that, you know, have disabilities, have had a stroke, have difficulty with communication, I know they're going to have difficulty registering, and I know that they really believe that it's important that they have a connected health system, and I'm happy to put effort into registering them.
And because they've got chronic illness, the potential for gain, having the record is greater.
The record is clearly going to be more beneficial for people with chronic and complex health conditions and older Australians, and also young mothers and young children, in fact, is the other priority group, Aboriginal and Torres Strait Islanders, rural patients. These are all priority groups for... But I just don't want people to get the wrong impression. The vast majority of people are going to be registering online, and the process of registering online has been simplified significantly over the last few months. For those that don't want to register online, they can still register by phone, they can register by post, they can go to a Medicare office, but practices who want to support this process now have a tool that they can do it with if they wish.
And online, Adrian, you've still got to have, you know, what your last consultation was, is that right?
If you're doing it online, yes, yes.
So that's a bit of a problem if you can't remember that. So that assumes that you've got chronic illness and you remember the last time you went to see your doctor.
Well, what you're calling out is that that we do need to have a process that ensures that people are who they say they are when they register. The last thing we want is somebody registering for somebody else's record, so there needs to be some security around the registration process, and fundamentally it needs to be information that is held by DHS Medicare that they can compare to their records to make sure that you are who you say you are when you register online.
And Adrian, are many hospitals registering patients using the ART?
Not many hospitals. We understand that the state jurisdictions are working very hard at the moment to implement PCEHR, and along with that assisted registration. St Vincent's, I think, is the only hospital currently that is connected to the PCEHR and performing assisted registration, with ACT Health shortly to follow.
And the carrot you're dangling is you'll get a discharge summary straight into the electronic health record if you're part of the St Vincent system.
Yes, I think part of the carrot for the consumer in the first instance is that we want to make sure that health information about them is shared with all of the health practitioners involved in their care, whether that's point-to-point messaging or direct into a GP desktop systems, or via the PCEHR. That's the carrot for the consumer. Certainly for the health providers, yes, wanting to make sure that GPs are connected with us, that they're receiving our specialist letters, they're receiving our discharge summaries, and that's a real benefit to the health community.
Eleanor, what if Janet had young kids?
So if she had children, dependents under the age of 18 that are on her Medicare card, we can actually register those through the assisted registration process.
And they don't need to consent?
Well, she's consenting on their behalf.
Right.
So we still need a consent form signed, but it's signed by the mother or father.
And an older child but who's still on your Medicare card?
So if they're over the age of 18, they'd have to register by themselves. And so, they could still register using the assisted registration tool. If you have a dependent who's over the age of 18 but unable to make their own decisions, then you need to register using the paper process, and there's a special section in the process, like in the booklet, that's section D.
So even though Janet rules her husband Tom with a rod of iron, she can't register for Tom?
Fortunately, there's no assisted registration for husbands. It's been requested a lot, but no, they do.
That would be very useful across the country. That would.
It would be very useful, but no, they do still have to make the conscious decision
the man into the
to
surgery
register
is
themselves.
going to be a bit difficult.
So I probably don't need to get right into the detail, but it is important for younger people listening to know that they can take control of their own record from the age of 14 if they wish.
We've got several questions here. One is from Judith Cowell, who asks, as an accredited mental health social worker, how do I register?
So as a mental health nurse, as a nurse, you're registered through AHPRA. As a social worker, I don't believe you're registered with AHPRA. If your patients who see you can get a Medicare rebate for the services you provide through the mental health scheme, the allied health scheme, which you can, then you will be eligible to get a health identifier from Medicare. And there's a process. It's a bit arduous, but it's getting better. And there is a process for getting the practice in which you work in, whether it's the general practice or associated of practices of health practitioners, to get a health identifier for the organisation, a HIPAA. And then that organisation can apply for a National Authentication of Health, a NASH. And then, of course, you need a compliance software if you want to write to this system.
But you can go to ehealth.gov.au and there's information there for providers on how to register, and that's whether you're a general practice or whether you're a solo allied health provider. The information's all there, and a solo allied health provider can still register and access the PCEHR through the provider portal, which you don't need conformance software. You need internet access for that. Once you actually go through the registration process.
So it's a browser process.
Yeah.
Question from Mary Garner from Metro North Brisbane Medicare Local asks, within aged care facilities, which healthcare providers do you imagine would share information to the PCEHR? Chris?
I think, well, I would hope all of the providers involved in the person's care are going to be sharing the information. So, that's going to be the GP, it's going to be the nurses involved in the care, it's going to be the pharmacists doing the visits. I don't think there's the social worker, there's the dental visits, there's the specialist visit. So all of these people, we would hope, would be contributing to the record, because that's what we're trying to do. We're trying to join up the health system, as Mikesh has said.
How do you do the event summary? How does that work when you want to add something to it? As you saw a dentist and you make sure that he or she's given the penicillin to cover, the heart problem, so to speak? These
are very good questions, and I've actually had the head of the dentist in the practice 2 days ago, and I've had the allied health people together last week. So these are very pertinent questions that they are really asking, and thank you for asking those again. So the way in which you do that is the same. To participate in the system as a practitioner, you've got to have those various prerequisites. Your identifier.
So let's say you're registered.
Yeah, if you're registered,
and you've done something and you want to add it to the record. What do you do?
Basically, you need to have a clinical information system that will allow you to do that. And to do that, once you have that, information on there is basically written by yourself electronically into your record. And I just did the first one in Australia on Sunday, by the way. So it's new, really new. It takes the information and data out of your system in the same way.
So you press a button to populate and off it goes?
Yeah, sort of, after you've done the 25 years of work before. But, but as far as the consultation is performed, you've got to be able to bring the information in, make sure it's in agreement with what you've formulated, agree that with the patient, that they're happy for that to be shared, and then it goes up as an event summary above the last shared health summary. So when you open the patient record, the PCEHR, the first thing you will see is the landing page where you can see the last shared health summary was created on this date, so many new Medicare events and pharmaceutical benefits events above that, and event summaries above that. So the first thing you see is a shared summary, and anything new above that, like the event summaries, and anything that's historical is beneath that. And there's other information that's available on the record as well.
Panos from Queensland asks, how are you going to cope with the new technology with the present telecommunications infrastructure of below average speeds, especially in remote areas?
Well, look, rural and remote health practitioners have dealt with adversity since time immemorial. That's what we do, It is hard to deliver health services when you don't have the same infrastructure as our metro colleagues. But the actual demands in terms of the data, this is not like video consults. The actual demand in terms of the amount of data that it's being transferred, it doesn't require high-speed internet connectivity.
But it does require real-time connectivity.
But it does require internet connectivity, absolutely.
Question from Joan Broadbeck, who's a nurse in New South Wales. Does this mean that prescribed medications will be shown in terms of the frequency that the client or patient is having their meds dispensed? So in other words, a checkpoint on adherence?
No, so this data is not that rich. What it's doing, as Chris has said, is gives you about 75% of somebody's medications, which tend to be prescribed and dispensed, and the PBS paying a subsidy on that. So it does not currently include traffic accident, it does not include private, does not include work cover. If it's sub $5.50 or sub $30 for non-pension holders, it's not on there. But that still means 75% is on there. But the actual data is then not rich around it. There are pieces of work being done to make sure that more of that information is available, and that's something we're working towards. But it's not ready right now, but we hope it'll be ready shortly.
But of course, medication information will also be available from discharge summaries, from event summaries, from shared health summaries, and that rich data set in terms of dose and modes of administration and details on how to take that medicine will be included in those documents.
And you can transfer that to the shared summary.
Absolutely.
As you go through. Adrian, have you got another question from Mary at Metro North Brisbane Medicare Local? How long it's going to take to spread to other hospitals what you're doing at St Vincent's?
Well, we understand that the jurisdictions are on what we call a critical path to actually implement PCEHR, and the time frame I understand about that is probably within June, July this year they will start going live with PCEHR. Naturally, state jurisdictions have to come up with their own plan on how they're going to deploy, whether they have the software that is capable of connecting to the PCEHR. But there's a lot of work being undertaken at the moment with the state jurisdictions to bring that.
There's a lot of work being done state by state, and it will vary. And some are at a different stage in their own internal technology and health projects. And some states have got some areas, I can name places like Albany in Western Australia that's ready to do some of this stuff, some places in South Australia, and some places that aren't. Barwon Health is doing some stuff in this area. So it really is going to be a
patchwork which will knit together. A question from Jenny Knight, who's at North Sydney Medicare Local. If you don't have a primary GP that you'd nominate for your PCEHR, can you nominate all the GPs that you've consulted with to be able to access my PCEHR?
Well, once you have your PCEHR, your eHealth record, anyone who's involved, any healthcare providers involved in your healthcare that you give consent to, can access your eHealth record, and so they can access it.
But how do I get a shared summary on if I don't have a primary GP?
No, you do actually have to go in and have that consult, because you have to go and have that conversation with your GP. You have to, speak to a GP that has some of your medical history. So a GP might not be comfortable doing a shared health summary for you on the very first visit. They might say, well, I don't know enough about you, and actually want to get some more of that information beforehand.
So the shared health summary also, in our build, 89% of people see the GP once a year. GPs are 96% computerised, so it's a good starting place. Mm. But any medical practitioner can be a generator of the shared health summary. Yep. Any registered nurse can be, and any registered Aboriginal or Torres Strait Islander health worker can do that as well. In general, the undertaking you make on providing a shared health summary is an ongoing relationship with the patient, and the patient has consented to you to provide that summary.
And I'd just like to comment as well that the evidence base around continuity of care is incontrovertible. You clearly get better health outcomes with regular contact with providers over time. So if you have a whole lot of different providers providing the shared health summary, technically you might be able to do that, but the quality of those shared health summaries are not going to be of the same quality as a shared health summary that's been generated by somebody who's known you over a decade and has been with you on that journey.
Rubbish in, rubbish out.
Well, excellence in, excellence out.
Oh, very positively. And I hasten to add that my question now has got nothing to do with a comment that I just made. Is corporate general practice playing ball? Yeah,
absolutely. Absolutely they are. So corporate general practice is everybody needs to make their own investment decisions around IT infrastructure, and whether you're a single allied health provider or whether you're in a corporate practice, you still need to make those decisions. So individual corporates are making different decisions along this track, but certainly there have been some big peaks in terms of registration when some corporate practices have got board, or groups of corporate practices have got on board.
A question from Jenny Donaldson in Macedon Ranges and Northwestern Melbourne Medicare Local asks, will the shared health summary provide an alert to the reader of the record if a patient has decided to conceal some medical information from their record? Is there a pulsating red light for Janet's depression?
The answer is no. This is a personal controlled electronic health record, so the patient may not have one. If they do have one, they may choose for you not to know about it. If you have someone who you go onto your system and know that they've got a record, because you can question the PCEHR system, it will then tell you the person has locked you down. And so to do that, to get access, you can still what's called break the glass with their, even if they're unconscious or there's a good reason for breaking the glass, you can look at that information. But if the patient's before you and they're saying you can't look at the record, obviously you can't look at the record.
And it's just like right now, you know, it's really interesting, but I've been in practice for quite a few years and I've never seen a red light over the top of somebody's head when I'm taking a history that alerts me to the fact that they've suppressed
but you can see it in their eyes.
They've suppressed some information. So it is just like the real world right now. Patients choose every day to not talk about health information with their providers. It's our job to make sure that a relationship is respectful and encourages that release, but it won't always happen.
So Eleanor, I asked you before, but I'm going to ask you again just to remind us, what steps does a professional need to take to register for this PCEHR?
So first you have to get those identifying numbers, so the HPIO, the HPII, and they're through the HI service, lots of acronyms there. And then you need to get your NASH certificate, so your National Authentication Service for Health certificate, and then register for the PCEHR. So you sign a participation agreement as a practice or as an organisation. And then once you get all that and get your conformance software or you get access to the provider portal, you're set.
And from beginning to end, does that take about a week by the time you get your CD in the mail?
A little bit longer.
Sorry,
a little bit longer.
Dr. Heikerwald just had a fit there as I asked that question.
Yeah, it does. It's a process. It takes time, but it's something that you only do once. And once you've done it, it's done, and you know it's all set. But you know, it is a process because these things need to be processed by real people, and there's a lot of practices who are signing up for the eHealth system. So there is a lot of workflow of processing.
Thanks, Eleanor. Now here's the final question for you watching on the webcast. As a result of watching this program, do you feel you have a greater understanding of the PCEHR and how to get started? Yes or no? I hope the answer is yes, but I certainly know more than I did before. Eleanor, there's a number of organisations out there who are there to help you. Just wanted to run through what's available for help. Well,
Medicare locals are there all around Australia to help provider organisations with the eHealth system. There's a couple of websites on your screen at the moment. So there's there's eHealth.gov, there's neta.gov.au, there's eHealthKit.com.au and eHealth-act.com.au, where there are resources available for provider organisations. But you can just give your local Medicare local a call and they can come out and help you, talk you through some steps, in the process of what you have to go through.
So Adrian, what's your take-home message for those watching?
For consumers and for practitioners, just connect, because we want shared health summaries in hospitals, because that's going to really benefit patient care in hospitals. And going back out into the community. Eleanor? Just call your Medicare local for help. I mean, it is confusing. It's not an easy process to start with, so don't worry about it if you're confused, because there are people out there to help you. We've done it with a heap of practices, so we're used to it and we can step you through it. Christopher? Well, rural practice has always been the great innovators in Australian healthcare, and I'm sure for the PCEHR it'll be no different. So get on board. Look, I do think it is hard when we go through all of this stuff. eHealth.gov.au, that's the landing page. It'll take you through all the education you need. The NETA website, right off the NETA website, there is a landing page about assistance, and it is targeted at the moment for general practice to help them register. We'll be reformatting that information for other health practitioners, but that information really summarises a checklist of what you need to do to get registered, not just for the eHealth record, and that's important enough, but for all the other stuff that's going as well, like electronic transmission of prescription, secure message delivery. So those two websites are critically important. Mukesh? Look, this has been a very difficult journey from the generation of the NASH certificate at the end of December, trying to get people registered for the practice incentive payment starting in February. And we know that people have had a lot of pain with that process. Nonetheless, once we get this through, what we've achieved in Australia is groundbreaking across the globe in being able to allow people to write to a PCEHR and read from a PCEHR, whether it's the community or the hospital sector, which means we're starting to get to a place where we can join up that care of that one patient from multiple places. It's good for you and I as healthcare professionals, and it's good for you and I as consumers, as patients in this place, because we've got better information
from a trusted source that we can refer to and get better care. So we need the critical mass of people out there, from the consumers and from us as healthcare practitioners, to make this thing work. And if there are problems, our job is to try and fix it.
Thanks, Mukesh. So, as a result of watching this programme, do you feel you have greater understanding of the PCEHR? A resounding 96% of you said yes. What a relief. And 4% of you no. Why 4%? Why couldn't it have been 100%? But look, thank you very much indeed. Thank you all for watching. A special thanks to Jenny Dibley, who was our actor today. I hope you've enjoyed this programme, found it useful. Well, 96% of you seem to have. And get started. If you're interested in obtaining more information about the programme, you'd like to watch the programme again, you can visit the Rural Health Education Foundation's website, rhef.com.au, and click on the programme page, Getting Started with the PCEHR, the Personally Controlled Electronic Health Record. And if you're a clinician, don't forget to complete your CPD evaluation form, which can be completed online. You'll receive a certificate of attendance and, if eligible, CPD points. We won't register you for your PCEHR. You've got to do that for yourself. Our thanks to the Department of Health and Ageing for making the programme possible. And, of course, again, thank you to you for taking the time to watch and to contribute so well to our discussion today. We'd like your feedback on the programme. Your comments are very important to us. Let us know you watched the programme by sending us an email or a text, and share your views. We'd love to hear from you. I'm Norman Swan. Goodbye, and join us again on the Rural Health Channel. The Rural Health Channel broadcasts 24 hours a week. To see what other programmes are showing tomorrow and for the rest of the week, jump onto the Foundation's website and click onto the RHC TV guide on the left-hand side.